when I was diagnosed, the only experience and reference point that I had about multiple sclerosis was learning about it in school and a neurological lecture about rare diseases. It's one of those diseases I learned about just enough to take my exam, and then it kind of left my brain for years after. And the other second reference I had was my favorite comedian, Richard Pryor. My MS was diagnosed incidentally on an MRI after I had been experiencing double vision for 2 years. So what I've learned through this process is just that MS is just an autoimmune disease. So my immune system, it starts acting funny and it just attacks the central nervous system. One of the key drivers of this disease is inflammation. So what my understanding when I first got diagnosed was that I had an autoimmune disease. It's caused by inflammation. And what happens is that I have my nerve fibers, which are surrounded by something called myelin, which is necessary to send signals smoothly and rapidly to the rest of my body. Because I had some damage to the myelin, then my symptoms were reflective of that damage. So when I see patients in the clinic, I always like to say that I think about my nerves as like that expensive, rapid iPhone charger that I buy. I don't know about your Droid users, but for the iPhone, usually the charging will happen within an hour, 100% charging. But then over time, that protective layer around the wires become frayed. And then you notice that your phone won't charge as fast, or it stops charging altogether, or you have to kind of angle it a certain way for it to work. It's the same thing with our nerves. When the myelin, which is the protective sheath around the nerves, becomes frayed and damaged, then the signals start to move slower or not at all. And then that's when we start experiencing symptoms. And that can be repaired to some degree, the myelin. However, even with the repair, the conduction or the translation of the message is sometimes slower. Next slide. There are several subtypes of multiple sclerosis. I myself, as I mentioned, have relapsing remitting multiple sclerosis. We'll start with clinically isolated syndrome, which is just your first episode of symptoms that happen for about 24 hours, and it's usually caused by inflammation or demyelination of the central nervous system. It's oftentimes difficult for healthcare providers to determine whether the symptoms are actually caused by damage to the central nervous system. And then when they do determine it's damage from the central nervous system, also trying to figure out the likelihood if that person will develop multiple sclerosis. So in clinically isolated syndrome, we generally don't wait to treat. We still treat a patient when we're able to identify a clinically isolated syndrome. The next one would be a relapsing remitting. 85% of the cases of MS are relapsing and remitting. These are acute relapses or symptoms that you experience, and they're followed by a full or partial recovery. And then we have secondary progressive, which starts with relapsing remitting and then progresses into a slow but steady worsening course. Usually 50% of those that start with relapsing remitting will progress into a secondary progressive MS. And finally, we have primary progressive MS, which is a steady, slow progression from the beginning. So your symptoms start, and then just over time, they just continue to decline over time. Next slide. Risk factors for multiple sclerosis. So when I got my diagnosis, like I said, I hadn't really heard much about it except for school and then my favorite comedian. And I often wondered if I could have done a little bit of things maybe differently for MS. And it looks like for environmental, usually occurs in more northern climates. I grew up in Pittsburgh, Pennsylvania. There's not much sun there, but it's often seen in the northern climates. And then also the other thing is infections. We know there's an association to those who've had Epstein-Barr virus or mono or the kissing disease. And I was 12 years old when I actually had mono. And just for the record, I wasn't kissing anyone, just in case my mom has signed on. I wasn't kissing anyone at 12 years old, but I did have Epstein-Barr virus when I was 12. Now, we have to be cautious when we say Epstein-Barr virus can cause MS. We know about 90% of the population is positive for Epstein-Barr, but we also know 90% of the population does not have MS. So we know that there's a correlation, but not necessarily a causation with that. Next slide. Okay. Okay. All right. So also, we know that women are 2 to 3 times more likely to develop the disease. So we not only carry babies in this world and other things that we handle, but we're also 2 to 3 times more likely to develop the disease. A family history. So I treat patients that have, mothers and their twins that have multiple sclerosis. So a first degree relative is oftentimes associated with an increased risk. When my diagnosis came, I remember learning in school that MS was a young white woman's disease. So, of course, when I received my diagnosis, I was clearly in disbelief because I'm not a young white woman. I thought it was just very strange. But now we now know that it's actually more common in Black people than once thought. And we also know that there's some variations in tons of genes that are involved in multiple sclerosis. One is the HLA, which helps the immune system distinguish the body's own proteins from proteins made by foreign invaders, such as viruses and bacteria. And we'll go to the next slide. There's also modifiable risk factors. I found this to be interesting, particularly as it relates to the African American community, because adolescent obesity in 2019, about 24% of African American adolescents between the ages of 10 and 17 were obese. And we know that that's a modifiable risk factor for MS. We also know that the obesity causes a chronic state of low-grade systemic inflammation. And of course, we know that MS, as a driver of it, is inflammation. Also, lack of sun exposure or low levels of vitamin D. We know that vitamin D plays an important role in stimulating the immune system to fight against infection and inflammation. When I was so I got my diagnosis at 21, I'm 40 now. And I remember about the age of 20, it was symptomatic in 2001. My diagnosis was in 2013. And then in 2020, I remember seeing a primary care, and they mentioned my vitamin D level was a 10. Well, I didn't take it serious. I didn't think anything of it. Actually, I thought, okay, well, it's bone health. I'll just drink more milk. I didn't have an understanding how significant vitamin D was to actually your immune system and inflammation and fighting off infections. So that was something that I had to learn. We also know another modifiable risk factor is tobacco use and secondhand tobacco exposure. It's associated with a more rapid progression of the disease. Cigarette smoke in itself has pro-inflammatory and immunosuppressive effects on the immune system. Okay. Next slide. Some of the common symptoms of MS. My first symptoms in 2001, my first symptoms were a numbness and tingling on the left side of my thigh, all the way down to my feet, in the setting of having a urinary tract infection. And I remember calling my primary care and explaining to them that I think I'm allergic to the Cipro, because all of a sudden I'm having numbness and tingling down my leg. My primary care sort of dismissed it, and I just said, that doesn't make any sense. So then I called the pharmacy and I said, I think there's something wrong with the Cipro. Again, I'm having numbness and tingling down my leg. And to come to find out, after I completed my course of antibiotics, the numbness and tingling went away. Little did I know is that I was having a pseudo relapse. So some of the most common symptoms are vision, double vision, blurry vision, optic neuritis or nystagmus, or vision loss. Sometimes patients present with that as their primary symptom. We also know there's an association with numbness, tingling, pins and needles, buzzing sensation, pain. I sometimes get tremors, internal buzzing and tremors that are not visible outwardly, but I feel them inwardly. We know weakness, muscle spasms, of course, balance issues, walking disturbances, falls, dizziness. We do have patients that come in, and that's usually sometimes their first complaint is that I'm always dizzy, not associated with anything else, but maybe some dizziness or some vertigo. What was new to me was as I've learned more about the disease. I always thought MS was just mostly a physical disease where, you know, if you have difficulty walking, it's really what I reference point for MS for me, because that's what I seen with Richard prior. What I didn't realize was there were so many silent symptoms to MS, which was the bowel and bladder dysfunction, the frequent urinary tract infections, the incontinence of urine, or the constipation that exists. There's also sexual dysfunction, where patients are not able to have an orgasm or have decreased libido. Fatigue is a major one. That's one of the other things that I battle with since the beginning of my disease has been fatigue. In fact, when I was in North Carolina, again, I hadn't been diagnosed yet. I remember going to primary care and complaining that I was so fatigued. I felt like I had mono when I was 12. And the route that we went to evaluate that was more of an endocrine route, where I was sent to be evaluated for like maybe a diabetes of some sort that can cause up to contribute to this fatigue. Cognitive dysfunction is another one that is oftentimes overlooked. Patients will come in and they'll complain about, you know, I'm having difficulty, you know, recalling the correct word, or remembering where I put something, or remembering things that used to come, you know, easy to me now are having difficulty with that. And there's a plethora of other symptoms that patients experience, but these are the most common symptoms. And the next slide. So in 2019, we thought that about 400,000 people in the United States had MS. And now we know there's almost 1 million individuals in the United States living with multiple sclerosis. Black individuals in the United States are more at risk of developing the disease than any other racial and ethnic groups. We can go to the next slide. So how do we get to this diagnosis? Well, when a person comes to our clinic and they come in with vague neurological symptoms, for instance, I have a little numbness, I have a little tingling, they're young, really can't explain it for any other reason. Maybe there wasn't an injury or you don't have diabetes. So we really try to get a very thorough history of when your symptoms could have first started. One of the questions we ask here in the office is, can you think back even to college or adolescence where you had an episode where you had some symptoms or weakness or numbness and tingling that lasted over 24 hours? Because to give a diagnosis of MS is a big diagnosis to give. So we want to be very clear when we give the diagnosis that we've gotten a thorough history and a thorough physical examination. Usually in our office, our initial visits are about 1.5 hours, sometimes up to 2 hours to actually evaluate a patient. MS is diagnosed by exclusion. So what does that mean? So pretty much we're trying to rule out anything else that can mimic symptoms of multiple sclerosis. And there's a plethora of tests that we run in our battery of labs. We do almost like 10 to 13 labs, then 10 to 13 tubes of blood for the amount of labs that we draw, just to be clear that we're not giving a diagnosis about MS, and it could be something else causing similar symptoms, such as like an arthritis or another autoimmune disease or fibromyalgia or even sarcoidosis. So we use this criteria called McDonald criteria, which are guidelines that help us to establish a diagnosis of MS. And what we're looking at in that is there's evidence of central nervous system damage that's happening in space, meaning multiple regions of the nervous system, and also evidence of central nervous system damage that is happening in different times or different points throughout the course. So if you're interested, I know the MS Society has a link where you can click for the 2017 McDonald criteria. It's pretty complex to look at, but from a provider standpoint, it helps us narrow in and be able to give an appropriate diagnosis of MS. Usually patients will have lab work completed, and then they'll have MRIs. We do MRIs of the brain, the cervical spine, and thoracic spine in our office, because again, it can affect the entire central nervous system. And then we also do a lumbar puncture a lot of times. So we're looking for specific bands called oligoclonal bands, which gives us signs that there is inflammation in the central nervous system. I know when I first got diagnosed, I had the MRIs, which showed lesions, about 10 lesions, but we also did a lumbar puncture, and I was positive for the oligoclonal bands. And next slide. Factors that can lead to a delay in diagnosis. Like I said, when I first had symptoms, it was in 2001, and the diagnosis came 12 years later. What's interesting is that it was once thought, again, to be a young white woman's disease. And I identify, of course, as an African-American woman. Both my parents identify as African-American. And I did my ancestry DNA, I did 23andMe, and I did my ancestry DNA, and that determined that there clearly is some European descent there. And if you look at our rich history, it would help explain how our genetic makeup is not as clear as we think. And there still remains a mistrust with providers. I know when I got my diagnosis, I was looking for someone that looked like me, that sat across the table and looked like me, because it was a very troubling diagnosis to receive. And I wanted to be comfortable in the providers that I had managing my care. So that oftentimes deters us from actually getting care, following through with care, and gaining trust of our providers if we don't feel comfortable in that setting. There's also health disparities, lack of access to healthcare or an MS specialist. Lower income, people can't afford the copays to come. They can't afford the copays for the MRIs. Lack of education about the disease itself, and just overall not understanding the complexity and the seriousness of the disease. Transportation issues, patients can't come to follow-up appointments as requested by the provider. And sometimes they feel a little bit ashamed about that if they don't get tests completed when they do get to the provider, because they couldn't get to their testing sites. And also health insurance issues also play a factor in that. And again, as I mentioned, when we do the thorough history and physical, we know that a lot of these symptoms can overlap other things. Like I said, I was sent to endocrinology. I'm thinking maybe I had some diabetes. Lupus is another thing, or Lyme disease, vitamin deficiencies, and other autoimmune diseases. As I think back in about 2005, I had another symptom where I had numbness and tingling in my left hand. Well, I had been working in neurotrauma critical care for so long, my provider thought maybe I just, I pinched a nerve in my neck. And so the symptoms lasted for about 2 weeks and then just went away with rest. We can go on to the next slide. So again, in relapsing remitting, you may not experience another relapse for several years. Therefore, symptoms are silent and the diagnosis is delayed further. We all consider that the brain's ability to compensate for damage can prolong its detection. So if you have a relapse and then you rebound and you completely recover from your relapse, sometimes you just think, oh, that was odd. I had numbness and tingling for a day or two. Maybe I slept wrong. And so we don't think anything about it, because oftentimes we recover from that neurological incident. We also use the term in neurology, neurological reserve, which is the brain's capacity to retain function by remodeling to compensate for the loss of nerve cells and atrophy. Others have used the term neuroplasticity. It's the same sort of concept. Within neurological reserve, we look at brain reserve, which is the physical quantity of brain tissue present. Providers, when we look at your MRIs, we're looking at atrophy of the brain. We know that patients we know the general population at the age of 30, the brain starts to shrink a little bit, but we know with MS, the brain shrinks a little bit faster. And we also look at cognitive reserve, which is the brain's ability to process information and compensate for the damage. So overall, once the neurological reserve is exhausted, then progressive MS starts. Okay, and we can go on to the next slide. So the reality with MS in the Black community, again, we know it's a higher risk of MS in women, but we also know it's a higher risk of MS in Black women. Black men with MS have worse outcomes. It's a more aggressive disease course in Black patients with MS overall. Black patients are likely to have more optic nerve and spinal cord involvement. I had double vision for 2 years, again, before my diagnosis. And I just kept going to the eye doctor and I kept having my glasses readjusted where I had prisms put in my glasses, but it was an unexplainable double vision for 2 years. Black patients are also less likely to experience complete recovery after a relapse, and there's shorter intervals between the relapses, and we also have more frequent relapses. We have more balance of walking and cognitive disabilities, and again, an earlier onset of disability. And when we present to the provider, generally we have more symptoms at the time of presentation and diagnosis. And there also exists a knowledge gap and best practices for Black patients with MS, simply because we are not as represented in the clinical trials for MS. By oftentimes we just don't enroll in clinical trials. And so there's a big push to enroll in clinical trials, whether it be a registry or a trial altogether, especially if you can't afford co-pays. We always advise to just look into a clinical trial so that we can get some more data for how MS is managed in Black patients. And the next one. Next slide. Okay, so what does all this mean for the Black community? The earlier the diagnosis and the earlier the treatment with a high efficacious disease-modifying therapy, the greater the chance we have to slow down the progression and minimize disability. I will say that when I got diagnosed, again, I didn't really have symptoms. I had a few relapses here and there. I had about 10 or 12 lesions on my brain at that point, but I was functioning. I was able to complete school. I was able to become a mother. Everything was fine in my mind. I thought everything was well. What I didn't quite understand is that even though I didn't have any outward symptoms, there was still disease activity ongoing. And eventually that ongoing disease activity that may not present now will present later on in life. And so had I kind of known that, I would have probably started treatment a little bit earlier. I went about 5 years of my diagnosis without treatment because I felt fine. I didn't think I needed the treatment. But now I do know, and I educate all my patients that come in who choose not to have treatment about my experience and how I wish I would have done things a little bit differently and kind of known that fact that even though my MRIs were stable, even though I didn't have symptoms, the damage that was there or the damage that's not identified in the MRIs can present itself later on in life. And that's something that I would have to deal with later on. And next slide. All right. So what is the relationship with your provider? The provider gives the diagnosis, develops a treatment plan, discusses disease-modifying therapy, monitors labs, MRIs, and provides referrals as necessary. When patients come in to see me as first, like a brand new patient who we're evaluating for MS, I will tell you oftentimes patients will just tell me what they want to tell me. And I explain to them, I want you to tell me everything you can think of, even if you don't think it relates. From a neurological perspective, I may be able to kind of piece those pictures together and actually see that there is something more worth investigating. So it's important to tell your provider about any bowel bladder issues, any depression, any sexual dysfunction, any sensory or motor issues, memory or cognitive issues, and most importantly, ask questions and please follow up regularly. I was one of the patients in the past who I'd see a provider once a year or once every 2 years. I thought everything was fine, but I now realize that had I had closer follow-up and actually seen my provider maybe every 6 months, those subtleties that I was experiencing that I dismissed as insignificant were actually significant and likely changed my my outcome of my MS and maybe would have changed the treatment options that were provided. Next slide. And final thoughts, I say to just give yourself grace through this journey. I, again, know when I first got diagnosed, it was life-changing. I didn't quite know how to process everything. When I got the diagnosis, like I said, I was in such disbelief because I didn't imagine that that was something I would experience, a diagnosis of MS. And I will tell you that it can get you down a little bit at times. But what I've learned is that it's a life-changing diagnosis, but it's not the end of your story and you can recreate your story. And don't be afraid to ask for help. I know I'm one of those people that I can do it on my own. I'm that person that's in the grocery store who stands on the second shelf to get something in the back that I can't reach. I can do it on my own. Through this journey, I've learned to just ask for more help, and just, of course, choose lifestyle that promotes health and wellness. If you can, try to seek out an MS specialist for your care. If that's not an option to you, you're always able to see another provider to just maybe oversee that. If you see a regular neurologist that you're not happy with, you can always go and get an MS specialist to just get a second opinion on. And also, patients will come in and just say, well, how do I get used to the diagnosis? How do I get used to my new norm? And my advice to patients is to always go through like the grieving process. If it's something that is life-changing enough for you, give yourself time to go through the stages of grief, the denial part. And that's where I was at the beginning, like, I'm fine, this can't be it. The anger part, give yourself time to go through that. The bargaining part, maybe if I'd have done things differently, the outcome would have been different. The depression, mental health is huge with this diagnosis. And I always encourage patients to just always seek either therapy or see a psychiatrist. There's no need to live in depression. Those things can be managed. And it took me years to get to the place of acceptance of my diagnosis. But now that I've accepted it, I hope that my story will inspire others, and then they won't make the same mistakes that I've made over my journey with MS. And after all, we're all in this together.